Welcome, everybody, to our main medical center Portland EMS division EMS webinar. We're really excited to have you all here. We're going to give it a few minutes just to get folks settled into the room. Please know that we are in a webinar mode, which means I believe your camera and your microphone are disabled. If you don't mind, please make sure your first and last name is visible in Teams. If you cannot change your name to be what it is on your EMS license, please let us know through the chat. If you don't mind, your name and your license number in the chat, as well as the state you're licensed in the chat. Please also, if you don't mind, use the Q&A function for your questions, and we'll try to answer them as we go along. Really excited to have Dr. Joe Minichiello, our EMS fellow this year at the Maine Medical Center Portland's EMS division, as well as Eric Wellman, our EMS manager here at the hospital. And they are going to talk to you about ethics and decision making in EMS. And with that, I will turn it over to those two. They're going to do this together. I'll turn it over to those two to offer any additional introduction or logistics that they see fit. Eric and Joe, thank you guys very much for presenting today. We're excited to have you. Eric, if there's anything else you'd like to share with the group, please let them know.
Thank you. If any of you need certificates because you're out of state, just email me. I put some information in the chat for that, and they will get to you eventually. We do them about every month. So we'll have those for you. And thanks for enjoying the show. Joe, I think it's your turn.
Great. Yeah, and we'll collectively, we haven't predetermined, but Eric, if you want, I can watch the chat if you want to watch the Q&A or vice versa. That way that we can also see things as we go here. All right, so the kind of background leading into this topic was just kind of a combination of a couple interesting cases that have come up recently that we've been reviewing from the hospital side, and then some folks kind of reaching out to us for advice, guidance on some more complicated cases, both from medical perspective as well as the legal ethical side. So we said, you know what, there's enough really interesting stuff here to talk about, so let's just put this into one of these webinar sessions. So that's where we are today, kind of background for this talk. So this is going to be a combo of some medical and then some ethical decision making, really tailoring it to the pre-hospital side. And then, yeah, Matt can introduce us, but I'm here as the fellow. Eric's here as the EMS manager. Both of us have some pre-hospital backgrounds as well. No special financial disclosures here for this talk today. Couple objectives here. And then this piece I can defer to Eric because Eric's going to make fun of me, but that's okay.
Well, something that kind of happens around here is that sometimes we get an idea and we think we're going to do something really simple, and then we turn it into a giant project. And this one became something that was supposed to be 5 slides. And between Joe and I, and more Joe than me this time, we made it into, I think, like 30 or 40 slides. So we apologize up front. We're both very passionate about this topic. It's really important to us. So we just wanted to make sure you understood that there will be a lot of talking.
Great. And to this point, though, please, like we said, both chat and Q&A function, whichever is going to work better from you. Some people, for whatever reason, have access to one, but not the other. Drop stuff in, thoughts, comments, questions as we go. You don't need to just wait till the end. But without further ado, we're going to kind of start heavier towards the medical decision-making side, and then we'll get a little more to the ethical, legal side of things here. So what is medical decision-making? I mean, it makes sense that we are all clinicians, we are all making medical decisions, but truly medical decision-making, which we're just going to abbreviate as MDM going forward, it's this idea of making decisions on the fly in this fast-paced environment with limited info, and things are changing as you go. And there's a balance here of both using the protocols that are available to you in terms of what can you identify and then what can you do to act on it. And then also there is a piece of some clinical judgment, right? So protocols are a way of kind of setting the floor or giving a scope of things available, things to consider. But you as the clinician, and you are just that, you are a clinician who's still going to have some judgment, some say, and looking at the person in front of you, deciding what is or is not needed for that person. And that decision-making process is going to be both kind of looking from a science perspective of understanding the physiology and the anatomy of the person in front of you. There is some ethics that even goes into this medical piece. Like I said, ethics will come up later in our talk today. And there's the experience piece. You know, when you see your very first chest pain patient fresh out of EMT or medic school, it's really easy to always think, oh, this is definitely going to be the big scary thing. Over time, you start to get a little more of that nuanced experience of, oh, I've seen this thing before. This looks like pericarditis when I've seen that before. So there's definitely an experience piece that plays in here over time as you sort of redefine your own medical decision making as you progress in your career. The goal of medical decision making, though, is that it's assessing the initial info, weighing the risks of doing or not doing something for that patient, choosing the right course of action in that moment, but then continually reassessing and knowing that your initial decision is not what you are bound to for the entire time. And so really what I set forth is that the goal I think that we're all working towards is wanting to deliver care that is patient-centered, evidence-based, and this is where our protocols come from, is evidence-driven protocols, and that the care that we give is going to be ethically sound. I kind of put this together in my mind as this kind of a cycle, where really kind of step one is getting your initial data, which is your physical exam, your vital signs, your patient history, and then kind of picking the 1, 2, however many protocols that are then applicable to your patient. And that's where you're starting. And you're then going to interpret, which is to say, you're going to now make sense of, if you're, let's say, in the anaphylaxis realm, you're going to make sense of the exam in front of you. You're going to give your first dose of epinephrine. You're going to watch and reassess your patient. That's now getting over to the outcome piece. But then you still have to continually say, gosh, does this patient still have stridor and bad tachycardia and hypoxia? Okay, now I need to go back because I have more data that says I need to give more epi, or I need to be giving some Benadryl if I can. So the goal is that MDM is this ongoing cycle. It is not a single linear path. And you're making this decision making. Really what you're doing underneath all of this is you should be formulating a differential diagnosis for yourself. And this is multiple components in terms of thinking of, okay, what is the absolute life threat going to be here? Like, what is the thing that if I miss and I don't treat is going to kill the patient? And honestly, I do this for every single patient. And I think most people here would say they do this for every single patient. But I would challenge you, even the well-appearing, seemingly straightforward call, you should always ask yourself, what is the thing that could be behind all of this that I'm missing that could ultimately kill this person if I don't test for it or diagnose it? Really important to avoid tunnel vision, and we'll talk a little bit more about some bias in medicine here shortly. But bias in terms of there are different cognitive biases, tricks that your brain are going to play on you that make you want to just say, oh, this looks like X, I'm going to treat it as X, there's nothing else that this could be besides X. Inevitably, it's actually Y or Z because you just never thought about Y or Z. And your differential, just like your medical decision making, is going to be a fluid, adapting process as you go, as you get more info, as you start to treat for what you think is anaphylaxis. If it's not getting better, you got to take that step back and say, gosh, is this actually something else? What am I missing? And then a big piece I put at the end here is to reflect after calls as well. And this is partly where, you know, with like part of Eric's initiative of trying to get folks feedback on the priority ones that come in. It's really trying to get you that feedback to reflect and refine and say, this is what this ultimately was. How do I now change that script from that experience piece of saying, oh, when I saw a patient that looked like XYZ and responded or didn't respond to certain treatments, this is what they ultimately had. With this, I then kind of give a little just tease into the sense that mnemonics can be helpful when you're starting to form some of these differentials or trying to make sure you're not missing certain diagnoses. A couple of these mnemonics that you may or may not have heard of that I just throw out there, but just to kind of tease apart after. Certainly, this is a little more from the hospital side of things. So we talk about the vindicate mnemonic, which is something that for the truly undifferentiated patient, something that we're kind of running through in the hospital. And some of these things aren't going to be as applicable pre-hospitally, but for just the undifferentiated sick patient, thinking about vascular, inflammatory, infectious. I'm not going to read every bullet point on the screen, but this is a pretty broad scope to try and just remind you to think about in your belly pain patient, for example, that, oh, right, I could be missing a AAA here if I'm not thinking about a vascular cause of this patient's belly pain. And then you then refine that and say, oh, this is a 70-year-old male with hypertension and a long-standing tobacco use history. And now they're checking all those risk factor buttons for a AAA. And that's going to help you mold that decision-making piece more. It's really easy to upfront maybe forget about it, but then you're like, oh, I need to think about AAA. And oh, wait, my patient actually has a lot of the reasons for this. One that people also may have heard of, AEIOU TIPS, is really good for your altered mental status patient. Again, it's going to run you through a really broad scope to make sure you're going to have a good differential and you're not missing certain things. Like remembering to check the blood sugar on your patient. It's going to cop out that I for insulin, but really it's hyperglycemia. Is there a blood sugar problem that's causing this? To be thinking about infection, to always be thinking about poisons or toxins that are doing something. And then for syncope, one that I like is pass out. I got this from med school. But again, it's just reminding you to think about hypotension, vasovagal are certainly frequent things that cause syncope in our patients. But again, thinking about checking a blood sugar, checking a 12 lead, like these are the reasons all of these things exist, because you got to rule out these big scary things. And then one of my favorites is a mnemonic that kind of reminds you to not miss things, is the mistake mnemonic. And this kind of plays in with medical decision making as well as reminders of, as you go through caring for your patient, making sure you're not getting that early closure, making sure you're not missing something. And so just to walk through this one for a minute, it's asking yourself, does the story fit the presentation? Meaning, I got called for possible heart attack. I show up and I find a 60-year-old male who's clutching his chest, complaining of crushing chest pain and is diaphoretic. And oh yes, I get a 12 lead and there's inferior elevations in leads 2, 3, and AVF. Like, sure, that fits. But if you show up and you have that same patient who's kind of clutching their chest and is diaphoretic, but has a totally normal 12 lead, you're now asking yourself, gosh, what else could this be? You know, I need to remember abdominal things. Like, does this guy actually have gallstones that's causing his chest pain and to be diaphoretic? And so just kind of saying, is what's in front of me and the data I'm getting fitting, yes or no? That then ties into this information recheck of, as you get more info, as you get your vitals, you get your sugar, you get your 12 lead, is this all coming together, or do I need to broaden out and restart kind of what's going on? Getting your more detailed exam once you've done your initial assessment. The team input piece is something I certainly love to do on both sides of this, pre-hospital and in the ED. Like, you're in the critical care bay with a sick patient, shock for reasons that we don't know, just to look around the room and call out and say, gosh, does anyone else have thoughts to what's going on here? Because someone else might have picked up on a piece of history that didn't make it to you, or someone else has noticed a subtle exam finding that you didn't pick up on, and they can collectively help refine. So definitely using your team is huge. Continually asking yourself, what else could this be? Prioritizing those life threats and saying, gosh, if I miss the STEMI, that's going to be bad. If I miss the fact that this patient's blood sugar is 20, that's going to be bad. And then asking yourself again after the fact of, is the intervention that I just did, like, did it help? Did it not help? And especially if it didn't help, like, why didn't it help? Because the answer is that it's probably something else that you're just not thinking about. Giving a nod to now some of the things that your brain is going to do to trick you or try and lead you astray. So cognitive bias in general is this big umbrella term that just talks about basically those mind tricks that your brain's going to do that's going to set you up for failure, of something that's going to make your brain deviate from regular rational thought. And this is where sometimes for us to look and almost, Monday morning quarterback, look at a run sheet and say, oh, well, I clearly have all this data in front of me. This was obviously a STEMI. Like, how did this get missed? But we are not there in the moment. We're not there in the chaos. We're not there when the patient's laying on the floor between the bathtub and the toilet. Like, we don't have all of that playing in. We don't have the crying, screaming family members as often as you sometimes have on a scene. And so if we broaden this out, there are a couple kind of core common types of bias just to kind of call out and acknowledge, because if you are thinking about these, that's how you avoid them. There's the idea of an anchoring bias, which is to say you see something and you just grasp onto it, which is to say, for an example here, you go for a syncope patient, you're just going to assume that they're well appearing. This is probably vasovagal, and it very well may have been. But then you don't check vitals. You don't ask about their cardiac history because you say, gosh, this is vasovagal, we're done. You have confirmation bias, which is to say you get info that supports your initial impression, and then that gets you kind of down that narrow path and you miss the other pieces. Like having a seizure, and you say, oh, yep, this was probably seizure. This person has epilepsy. They obviously just had a seizure. And you never actually get the blood sugar because, yep, they seized. And so that can trick you and fool you from what you otherwise normally know, which is I should check a blood sugar on someone who seizes. The idea of an availability bias is to say, you just recently saw this cool or impressive, memorable case that you're then going to want to apply to everything else that looks similar to it in the near future. Which is to say, if you brought in this like chest pain, short of breath patient that ended up, you found out when you went back to the hospital had a giant PE, you're going to suddenly think everything looks like a PE because you just found this PE. The overconfidence bias is to say, you trust your judgment, which is a good thing. Like we want you to trust your gut in medicine, but to overly trust your gut and to say things like, oh, this is a 20-year-old female who is studying for finals at college. Like this is probably anxiety and panic, but you overlook the fact that they actually had an abnormal EKG because your brain just went and stuck with, oh, this is anxiety. The idea of premature closure is to say that you just chalk something up and you just, once you get to a point and say, oh, there's point tenderness on the chest, we're done. There's no way this is cardiac. I have reproducible chest pain. And then there's the idea of a framing effect, which certainly plays in a lot here in the pre-hospital side of things, which is to say, even just the initial call info you get, like dispatch, love our dispatchers, but dispatch is setting you up for failure. They are sometimes giving you a possible diagnosis before you show up on scene, or you get there and bystanders are telling you something like, oh yeah, he just looks drunk. And then your brain on its own is going to say, oh, this person's intoxicated. And you get to them and then you don't check the blood sugar. I think a great place that this happens, for example, is you show up on scene at an MVC and you have bystanders or police saying, oh, this person's obviously drunk, and then you never check the blood sugar and their blood sugar is 30. So all of these are things that aren't you necessarily intentionally trying to set your patient up for failure, but these are all things that your brain is going to do naturally that you should just be aware of and try and avoid. All right. I see no questions so far, but like I said, by all means, trickle them in as we go. Kind of our first case here is going to tie more to this medical decision-making side. So a couple slides here just to build this case up, and then Eric and I will chat about this case together. So it's 4 p.m. You get sent out for a person down on the sidewalk out in front of a cafe. It's a middle-aged male. Looks like he fainted. And then the caller doesn't know this person, but says they just witnessed this guy walking along the sidewalk and suddenly collapsed, but is now conscious and breathing. And in this case, we're going to say you're showing up with an ambulance that's at the A level, and then there's an engine coming that also has a medic on board. It's a nice day out. It's 70 degrees, not overly hot. It's sunny. You get a 58-year-old male who's on the ground, looks a little pale, maybe looks a little diaphoretic, is talking to you, is answering questions normally, is repeatedly apologizing for bothering you and saying, sorry for ruining your day, sorry to make you work, kind of that usual thing that we run through multiple times a day. And he's just kind of saying over and over, I don't know what happened. This kind of came out of nowhere. Bystanders say it was just about 10 seconds or so that he was out. They didn't see anything that looked like seizure. They didn't see any trauma at all coming up before this. Eric, at this point, kind of what are things that are going through your mind? Like, what do you want to do for this guy? What do you want to know?
So I'm thinking, initially like, okay, this sounds like a gentleman who ultimately passed out for a short period of time. So we're thinking potentially syncope here, but there's a lot of reasons that a person can go syncopal. So you could be potentially a cardiac issue, could be a blood sugar issue. We don't think there's any trauma, but trauma could certainly be a factor in here. We don't know if he's taken any medications or any other substances that may be affecting him. So there's a pretty broad spectrum of things here. So pretty much it's open-ended at this point. I'm willing to explore a lot of areas right now.
It's great. So let me give you some more info. This person, you kind of do your primary assessment, which for me, I always tend to follow a March algorithm. March comes more from the trauma side of the world, but I think it applies everywhere. So this is just my approach to folks. Now you're looking at this guy sitting on the sidewalk. You don't see any external bleeding anywhere. He's talking to you, so he has a patent airway. He's sitting there. His breathing's unlabored. You're not noticing it to be looking slow or fast, so it looks roughly normal. And then as you're kind of just squatting down next to him, you check his radial pulse, which is there, but maybe it feels a little weak. You get him hooked up to the monitor, put him on a 4-lead. His heart rate's 50. It looks a little irregular, but you're not quite sure maybe why it's irregular. So you're getting your 12-lead set up. At the same time, your blood pressure cuff's cycling. Here's your first pressure, 88/58. It's slightly low, but the map kind of comes out as over 65. So we're in an okay spot, but don't love that pressure. Respiratory rate, you end up counting it. Someone magically gets the number of 16 after counting those breaths perfectly free for a minute. SAT looks great, 96% on room air, and his temp is normal. So this doesn't seem like it's heat stroke or something related to that. And then because, like Eric said, there's a whole broad differential here. So checks of blood sugar, it's normal. And then that 12-lead finally gets set up, and it looks like a sinus rhythm. There are definitely P waves there, but having a couple PVCs, so that's probably that irregular look, is just throwing some ectopy in there. And then there's some non-specific T-wave changes to say that maybe there's some T-wave flattening in places, but there's nothing that says STEMI. There's no single cluster of places that looks ischemic. So it's not normal, but it's not a slam dunk STEMI. And then, wanted to know a little more about history. So here's some history. The guy says, I just blacked out. I don't know what was happening. Felt fine earlier in the day. Hasn't been sick recently. Just happened suddenly while he was walking. Now he still feels a little lightheaded, feels a little fatigued as he's sitting there. He's not having any chest pain. And then, Eric wanted to know some about his history. So here you go. He's got high blood pressure. He's got high cholesterol. He had a heart attack 5 years ago. Here's some meds that he's on to treat all of those things, his blood pressure and his cholesterol. Doesn't have any known allergies, says no alcohol or drug use earlier in the day. And then this is where really our crux of discussion will come in for this case. And this is not an infrequent thing by any means. The guy turns to you and says, I feel fine now. After a couple minutes of talking, you give him some water to drink. He's not feeling lightheaded or fatigued. He's kind of recovered from this syncopal episode. Says he's got an important business meeting to go to down the street. That's why he stopped to get some coffee before he went to his meeting. And says, I'm good. I don't need to go to the hospital. And so, again, with kind of emphasis on this one towards the medical decision-making, but certainly this is going to lead into the ethical side too. Eric, what's going through your mind for this patient? Like, is this person safe to refuse care?
So right now, the big things that are standing out to me, kind of the red flags, is his pulse rate's 50. His blood pressure is soft. And those two combined could mean that he has something significantly going on cardiac-wise. He could also have some medication issues. It looks like he does take medications that are vasoactive. So those are two factors. I'd want to know more about things like, hey, did you take a new dose today? Did you take an extra dose? Have you drank? Do you have fluids? Do you have those kind of things? There's a lot of questions I still want to have answered. I'm not necessarily comfortable signing him off right at this moment because I still have information that I want to know. And I'd also like to know what he's like, say, 10, 15 minutes after this, if he recovers, if he has materials there or anything like that, if anything's developed, if he's developed chest pain at that point, or any of those things. So I still think he's got a few things. He could probably benefit from some IV therapy fluid. But again, like I said, we need to see what's see a couple more things here.
Sure. So let's say he agrees to an IV on scene, you get a little fluid going, but he still doesn't want to go to the hospital yet. What, from your perspective, like both kind of medically, but teasing a little to the ethical side, like what are your obligations as a provider in this setting? Like what do you feel like you need to do versus what is that balance to say, gosh, at what point can this guy refuse even if I don't want him to?
Yeah, and I would say the first thing I need to do is to make sure he understands the nature of what's going on here. Like the risk factors that I just discussed with you would be discussed with him. Like I currently see that your blood pressure is low. I currently see that your pulse rate is low. Those together are not a good combination. And I don't have all the resources here to determine why your condition may be this way. I don't have blood tests. I don't have ultrasound. I don't have a bunch of other materials that could be potentially beneficial to you. That'd be my first thing. So I want him to understand what I'm seeing and what I don't completely understand what's going on for his case. But I'd also want to know that he could really understand that too. I'd want to make sure that he was, conscious, oriented, alert, that he was aware of where he was, who he was, what he was thinking. If he could really understand what I was saying, those are like the big things. The other thing I think about in this too, is sometimes language barriers. If we don't speak the same native language, there's going to be some communication errors there too that just pop out. But I really want to make sure he has decision-making capacity and he truly understands the nature of the case that he's involved in.
Great. Well, I'm starting to hear some talk about capacity, which is something we'll get to in a couple slides here, and knowing, is this person able to refuse in the first place? We'll talk about that more in a second. But yeah, like this person needs to be aware of the risks. Like, gosh, I'm not sure why your blood pressure's a little low. I'm not sure why your heart rate's a little low. That combination of things is certainly interesting, right? A low blood pressure with a low heart rate, certainly puts me in the realm of thinking about medications. We know he's on a beta blocker. Did something change there recently? Like you said, you don't have the labs or other data to necessarily guide that. So let's say you have this discussion with him, you feel that he has capacity to refuse. Documentation wise, not to state the obvious here, but what are you doing to now cover yourself and your service once this guy, you've decided, yep, he's okay to sign off, I don't agree with it? What are the things that are absolute musts for you for documenting this?
Yeah, so again, it would cover many of the same things I just discussed. Like we're definitely going to show that he had decision-making capacity by showing he was conscious, alert, talking about whether or not he had any evidence of intoxication. So I'd clearly state that his words weren't slurred. If he didn't smell of alcohol or any of those things or have any ingestion issues. I would go into probably a good discussion about, is he getting medical care? When did he last see his doctor? Factors like that. Did he change anything in his did anything change in his medical history? Like, did he say, oh, I did take an extra pill today, or things like that? I'd also probably, if he did not respond to any fluid treatment or any of those things, I probably wouldn't feel terribly comfortable signing him off. And I'd probably involve medical control. I'd talk with a doc and have a doc talk with him too, just to go that route, just to make sure that there was anything that I might have not thought of that they could miss, or they might be able to pull up through his history in the charts to see that.
Great. And I will say, the other thing I'm a big fan of here too is if we're signing this person off, I'm very pro the witness signature and just trying to get that extra person that's going to help cover you that much more to say, whether this is the person that's going to be caring for this person or staying with them, or it's a bystander, or depending on the setting, it's a law enforcement officer who also witnessed your discussion. Just that extra signature, I feel like carries a little extra weight for that situation when someone tries to turn around and be like, you didn't actually talk to me about this. You have an extra checkbox that says, yep, you actually did. And then let's just put into context here, right? This was a 50-something-year-old guy with a cardiac history having concerning things. This is a high-risk syncope. If this was a 25-year-old person, you're with no cardiac history, like, do you still feel as strongly about this, or how does that change for you if I told you this was an otherwise healthy 25-year-old?
Yeah, so in this case, like when you say to me, he's got a cardiac history, he's got all these things, he's 50 years old, these things make sense in the sense of like, it could possibly be a medication issue because he's got medications that do this and those kind of things. Now, if this is a 25-year-old, he has no history, these are odd findings. this is not something that stands out. This is somebody who probably needs to be seen for various reasons. Now, it could easily be explained away as well. They're dehydrated, but that's again doing that bias piece where I'm like, oh, well, it seems like a reasonable solution to that, and I want to convince myself of that. So yeah, I would say I would actually be even more concerned for that person, and I'd want them to be seen by a physician.
That's great. I agree completely. All right. Well, let's kind of swing with some of these discussion points coming up. Let's start to swing in here.
We have a question. We have a question from the chat.
Oh, what do we got?
We got recognizing my own gender bias. The commenter is female. Patient is male. Does he have a significant other? Will patient consent to allowing clinician to call partner? Reading is a twofold. Can confirm baseline history, meds, etc. And secondly, can they convince patient to accept transport?
Yeah, I mean, I think that's great. I think Eric hit on one of the big resources here, which is to use medical control. And sometimes, even though you all on the scene know just as much as I know, sometimes just when you say, oh, I'm Dr. So-and-so, I think you should come to the hospital, for whatever reason, that does carry a lot of weight to it. But yes, the piece of whether they're on scene or available by phone, sometimes that family member support person can also then convince them and say, hey, someone that knows you well, or can I talk to someone about you? I'm worried. And it's both kind of twofold. If they're not going to be able to at least convince the person, then I also like to know that there's someone that also now has this person on their radar to then check in on that person later in the day. So yes, I love the idea of seeing as a significant other or just an important person in that person's life. It can be tough, right? Because you're trying to balance getting yourself then potentially available for other things that come up. Like you don't want to spend an hour on scene with this person. But yes, I do love, if the med control piece doesn't work, getting someone else who's going to be able to be aware of this person if they're not immediately on scene, I think is a great option also. All right, swinging a little more to the ethical side. Eric's going to take the lead a little more on this half.
So thanks to Joe for much of the great work that's actually done on these slides. This is not AI, this is Joe. So when we talk about ethics and decision making, we really want to make sure we understand the three major components of how we evaluate something. So you have legal, ethical, and moral. So when we talk legal stuff, that's functionally sets of laws that have been made by an administrative body, a legal body, a legislative body that kind of basically says this is how we're going to do things. So in many cases, your speed limits, those types of things, those are all set by law. And law doesn't always account for ethics or morality. It is its own piece. But they generally set up the kind of the things like, as Joe's put for an example here, mandated reporting. Each one of us is a mandated reporter. We have to report child abuse types things. If we don't do that, then we can be held liable for that, for failing to do that. What we're predominantly going to be talking about today is ethical decision making. That's professional principles. So as a EMS clinician, you have a code of ethics that you follow. You have standards that are expected of you by the profession itself, but also by society that believes that we're supposed to act in a certain way. Joe's example here is that we respect DNRs when we come in contact with them. That's a professional principle. And then finally, morality or moral code. And again, that's a more personal piece that you derive from your own experiences with the world in itself. And those in your moral compass can be formed by from legal principle and from ethical. And you can argue that legal is also influenced by ethical and moral principles also. So they all kind of interrelate, but these are the specifics of them. And functionally, when you look at moral pieces, this is when you have dissatisfaction with certain things in the world. When you experience a moral injury, that you have a belief that the world is supposed to work in a certain way and it doesn't, or you've been promised that it will work in a certain way and it chooses not to. Joe, I'm ready for the next slide. So one of the biggest things we want to talk about is that we spend our time trying to figure out if a person has decision-making capacity. What we don't spend our time doing is figuring out if they are legally competent to make a decision. And I think that's kind of that's a twofold thing. And we really want to understand the difference between those. When we do capacity, we do an assessment to figure out if the person understands what's going on in their world. So that's why I talked about some of those pieces earlier. When you want to understand, does the person know, one, are they conscious oriented alert? Do they know who they are, where they are, why they're there? Are they capable of understanding a decision that you explain to them? If I give them that information, can they actually make that decision? And so functionally, it comes down to that we look for decision-making capacity when a person is going to make a decision about their healthcare, such as I'm going to refuse care from you, or I'm going to accept care. We put that in there. We obviously have some legal terms like implied consent and consent in itself that fall throughout these areas of capacity also, that allow for certain things when people are incapacitated. And competency really does come from the court system. So you are determined to be competent by a court of law. And that's when you end up either having to have a guardianship or a receivership in order to manage your functions if you're determined to be incompetent. And someone else has to make decisions for you in order to keep you safe. And that can be in different mechanisms and things. But we do not necessarily we may have to deal with the competency piece after the fact when someone has to have a guardian make a decision for them, but we don't necessarily determine that a person is competent. We determine that they have capacity. And that's a really important piece to remember. And I think Joe has a great note in here too about that your capacity changes, because if I give you a certain medication that has a mind-altering effect to it, suddenly you may not have capacity any longer to make those decisions.
Great.
Ready for the next slide, Joe?
Yeah, and while we're here, actually, Eric, we got another question in the chat.
Oh, we do.
Along the lines of DNRs, which is to say, can we accept a screenshot of it? Sounds like in a certain moment, crew didn't necessarily feel comfortable with the screenshot and didn't. Patient agreed to be transported because they wanted to go to the hospital in the moment. Medical consultation that they pursued at that point wasn't clear on it either. This is an interesting spot, and I'm actually curious to hear both kind of Eric as well as Dr. Scholl's thoughts on this here too. I mean, I think the technical answer is that you should have the piece of paper in front of you. The other interesting thing that comes from this, and I will tie back to say that there's an entire hour-long webinar that Dr. Michelle Crispo gave a couple months ago on YouTube that talks all about these two. There's also a difference between the DNR and a PULST. And so DNRs tend to guide a little more along the lines of like, would I want artificial nutrition? Yes or no? Like, do I want to be kept alive if I have a reversible or irreversible thing? Yes or no? Whereas the PULST is a physician or provider order that specifically says, do chest compressions, yes or no? Intubate, yes or no? So just want to clarify that there is going to be some difference as to what these different documents have in terms of saying what someone does or does not want. But in terms of accepting a screenshot of it over the paper itself, I'd be curious to hear thoughts from Eric and Dr. Scholl on this.
I'd be willing to say if I could clearly make out that it was a DNR, that I could clearly make out it was for our patient, that I could clearly make out all the signatures and everything else that's involved in it. And if I was really feeling skeptical about it, I could take a screenshot of it myself in exchange. I would feel comfortable with going that. If it was questionable to me, I could call the hospital and see if they had it. Sounds like in this case, that wasn't necessarily an available option for them. But I would be comfortable potentially following that. And I'll give it to Dr. Scholl.
Yeah, so thank you. So this is an interesting question. It's an interesting question for a couple different reasons. In this case, the patient was actually awake, alert, oriented, able to, or at least awake and able to participate in the conversation, and agreed or wished to be transported. I think this is an interesting situation in that regard because the patient was able to participate in questions around their healthcare status. In general, having a physical copy is always optimal for a couple different reasons. It is the legal document. It can also be passed on to downstream providers at the hospital you're transporting to, or at subsequent hospitals the patient goes to. And it's nice to have that legacy of the patient's wishes to go with them, whereas a screenshot doesn't afford that. I will say, if you, as Eric mentioned, if you can clearly make out the signatures and the intent of the document, and clearly make out that it is indeed a DNR document, and it is commiserate with either the patient's or the family's wishes, i.e. everyone is everyone is agreement that the intention of the document is the intention of the patient, then I think it is reasonable to follow the guidance of that document. If there is controversy, though, and there is something that the document says that the family counters, that's where it's very important to discuss with online medical consultation and try to reconcile those differences between the two things. And again, if the patient is awake and has decision-making capacity, is oriented, is engaged at the point of patient care and can support decision-making, their word is or their statements about their wishes are sacrosanct to us as EMS clinicians. We should follow those.
Great. Thank you both. And yeah, I think kind of even that clarifying piece, the DNR is from out of state. It's okay where it originates from. I think similar answer, if the paper's not available, though, just kind of doing your best that everyone's in agreement, then great, proceed as such. If not, getting online medical consultation to help make those decisions in real time. Kind of, as Eric had just talked through, capacity, a person is able to also then make changes as they go on throughout too. Yeah, so I think between kind of like what's already been said, if there's dissonance in what the thought is on scene, getting online medical consultation involved to help make those decisions in real time, because some of this is a little fluid as you go. All right, Eric, here's your next slide.
Our 4 pillars of medical ethics. So when we think about a patient, one of the things that we want to think about from our professional standards is that patients have autonomy. Our decisions need to be beneficent, which means acting in their best interest, not our best interest, but their best interest. Non-malfeasance, which means to do no harm, and to make no actions against the patient that would be harmful to them. And then with justice, which is fairness and equitable treatment. So regardless of who the patient is, they receive the same care that everyone else does, and the care that's appropriate for them. This is a key component to the underlying belief system of medicine. So it's important that this is something that you engage in with your patients. So when you want to make good ethical decisions, you got to look at certain pieces of this. I actually start with the whole thing of you have to understand what your biases are in many situations. You may have things that trigger you as to being sensitive subjects yourself that tend to make you fail to see through the cloud sometimes. So when you're given certain facts and such, you want to make sure that you understand where you're coming from to make sure that you go past those situations. But everything is functionally a discussion between you and the patient. And the patient has decision-making capacity, so you want to make sure that they're involved in what's functionally called the shared decision-making process. So you want to look at what the best outcome for the person is and give them their options. Like, hey, if we do A, B, C, and D will occur. If we do, Z, X and Y will occur. So it's important for them to be able to do those things. So, and then you have to document that piece and you have to communicate that effectively. And how did you make these things happen? What did I do to get to my decisions? And then ultimately, everyone's favorite part, which is the documentation piece. I cannot stress how important this piece is. A good portion of my day is spent reading EMS documentation and trying to make heads and tails of certain things. But it needs to be clear, objective, and complete. And I think one of the struggles that all of us have is we have a bias when we write things too. We think people think like we do when we write something down. So we may only write a brief statement and we know what it means perfectly fine. But I hand it to Joe and Joe doesn't think like I do. So Joe reads it and interprets it an entirely different way. So it's really important to make sure that when you take a note that is definitely going to get handed on to somebody else, that they understand that you are using clear, precise language that truly means what you meant. The other thing that we really want to talk about is your judgment of others should not be in your documentation. We see this in multiple ways, but if a person has done something questionable, documenting that in patient care documentation probably isn't in anyone's best interest because it's part of the patient's chart and it will show up elsewhere in their world. So you want to try to avoid doing that. There may be a better place to put that, like an incident report or a follow-up report or an email or whatever may be with that. Obviously, quoting anything the patient says is always recommended. So this last one, which we hear a lot, I've heard in 32 years of EMS, is if you didn't write it, it didn't happen. And I now put a little dot next to it with a little asterisk to just remind you. Yes, that is absolutely true. Documentation is the best way to do it. But sometimes you do go on calls where something so weird happens that you never, ever forget every intimate detail of it. And if you wrote a terrible run sheet, you may actually be able to recall everything from it and speak about it intelligently if somebody asked. Now, the difficult problem is, though, that's only if somebody calls you or calls upon you to give that information. So it still doesn't end up in the chart. So the key thing to remember is that documentation is the legacy for the patient. So it's stuff that gets handed on down the road. Other people can see it and they can see what you did. And again, teamwork. Everything we do is teamwork. Involving others, emphasize the shared decision making, bringing your supervisors into these things at times. But again, bringing in the right people for the right reasons at the right time. Many of these things you can generally do between you and the patient and come up with the best plan forward, but it's always about what's in the best interest of the patient. I think it's really important to remember that our goal is to support the patient's autonomy, to remember that we're trying to do what's best for them. I have one, reread your PCR far too often. The wrong receiving facility is used to copy and paste an accurate chart. Yep, I can tell you that one too, because I do get a lot of reports that actually are supposed to end up at Mercy. So, case number 2. All right, in this case, it's 22:18 hours, so it's in the evening. We're dispatched to 221 B Street. It's going to be for a fall with a head injury outside of a bar. Now, if we were talking bias right now, I bet you some people already have some images painted in their head about what we're about to deal with for a call. You're on an AEMT ambulance with a paramedic by fast response vehicle also being dispatched. Currently in this, you're on an urban sidewalk, dim lighting. It's a moderate foot traffic. It's a clear 58-degree Fahrenheit day. There are several bystanders, including bar staff and patrons. You are responding to a 34-year-old female, Caucasian. She's approximately 140 pounds and 5'6" in height. She's wearing casual attire, no coat. I tripped and hit my head. I'm fine, just embarrassed. She's complaining of head pain and mild dizziness, and she has a noticeable abrasion on her forehead. So, Joe, where are you at?
Yeah, so I mean, a couple things go through my mind. So one, like Eric said, you initially get this call, and maybe at 10 o'clock in the evening, maybe you were already in bed for the night, and now you're getting out of bed to go on this call. But so you're getting there, you might have this bias of what you're going to expect or anticipate seeing. But a couple things that go through my mind. One is, before I just call this person drunk, certainly want a blood sugar. I'm getting blood sugars on lots of patients. But to me, like, I need a blood sugar here. I need some vital signs here. Is there a medical reason why she's having this kind of dizzy feeling? Is there some hypotension? Is there something else playing in here? And then I'm going to want to just know more kind of physical exam wise, like if there's this abrasion on the forehead, are there other injuries that we're missing? And then other pieces that I want to know is like, what is her intention going to be? Is her ultimate goal here, she wants to go back home? Are there friends with her? Are we going to be heading more of a hospital direction? I need a little more info to get a sense of what this patient's course is. But at this point, I want a little more of a full secondary assessment. I want some vitals, get a little history, kind of the usual things, because I'm needing to figure out at this point, like, is this person going to need the hospital? Yes or no?
Absolutely. And I think it's good that you mentioned the both the medical concern and the traumatic concern, because this does seem out as on the surface level, it seems like, oh, it's a trip and fall kind of issue. Great, it's traumatic in nature. But you're right. What made this person trip and fall? Was it just stumbling across something, or was it that they had a syncopal episode and then went down on the ground?
Great.
So our airway's patent. We have unlabored breathing. We have no major bleeding, just that abrasion. GCS is 14, eyes are 3, verbal 4, motor is 6. You know what? That adds up to 13. I think the eyes are 4. Let's go with eyes are 4. Verbal
Great.
is 4 and motor is 6.
Okay.
And our BP is 132/84, 88 beats per minute for heart rate, 16 respiratory rate, must be hanging out with the other guy. O2 sats 98%, normal temp. So we do have a blood glucose of 102, putting it in normal ranges. We have an EKG that's normal sinus with the 12 lead that's no acute findings. And we have an end tidal of 36. Now, some of you may ask, like, oh, you just loaded up all the signs on here. I said, but when designing this case scenario, one of the things I thought about is these would all be things for this patient that I would potentially actually check. And again, even the end-tidal CO2, because if I was looking at the underlying factor that she might have a head injury, end-tidal CO2 is a major component of that. Joe, is so far any surprises here for you?
No, I mean, this is kind of fitting with, again, kind of where the bias or the initial impression is leading into this. Again, I'm walking through back to the medical decision making side, like what is my most likely diagnosis versus what are the killers, what are the things that if I miss are going to be a problem, and a lot of those are starting to come off of the table for me at this point. We have a normal sugar, we seemingly don't have a cardiac problem here, seemingly don't have a respiratory problem here. Nothing else really big that jumps out from an exam side. We'll get a little more patient history here in just a second, I think, but nothing is necessarily like, oh my gosh, red flag yet. I am thinking about this GCS kind of 13, 14 piece of, okay, where are we at with this person, as I do kind of think more about their history, and we'll talk a little more about capacity here, but nothing too surprising yet for me.
Great. So our history is our patient did trip on an uneven sidewalk while walking out of the bar, fell forward, struck their head on the pavement. No loss of consciousness, ambulated without assistance after the fall. Does have a little bit of alcohol on board, so does emit to a couple drinks. Does have the odor. Headache and mild dizziness. Does have has 2 beers and tripped on the sidewalk. So functionally, that's what you got, Joe. What do you think now?
And I'm thinking I'll just jump to the next slide, Eric, if that's okay too.
Sure,
kind of
absolutely.
Lead into this piece. Because this, I think, is where my mind is going for this person, is what is our disposition going to be here? What, and again, kind of the earlier points, like what is my obligation? What are my protocols say I should be doing versus what is this person going to want? In this case, we're kind of reframing it that this person says, I'm fine and I want to go home. And one of the things that go for me here is, again, back to that, GCS of not 15. Alcohol is a really interesting thing to talk about when you talk about the capacity discussion here. Does a drunk person automatically lose their capacity? The answer is no. But if you feel that someone is impaired by substances beyond the ability to then answer some of those capacity questions, can this person actually show that they have insight into the risks? Can this person actually repeat back to me what my concerns are? Can this person actually share with me why they don't want to go to the hospital? And is there, whether I agree with it or not, is there a reason that is kind of consistent in their wishes? And if that's the case, then again, I am thinking, getting online medical consultation involved here, because I have a possible, not even possible, a head injury, right? This person has an abrasion on their forehead. They struck their head. So I have a head injured patient who has an altered GCS. I mean, the textbook says this person should go to the hospital, and that's what I'm going to advocate for. But really, my next thing with her not wanting to go is I'm now doing a capacity assessment, and then I am seeing, are there other friends or family members around that I do feel have capacity to care for her? So that's kind of where I'm initially thinking when this whole "I don't want to go with you" comes up.
Yeah, and I would say you're definitely not wrong there, because you kind of highlighted all the major things. Let me ask you this, what would take you to saying, no, this patient absolutely needs to go to the hospital? Like, if I was the medic calling in for this, what would make you say, no, you need to take them in there right now?
Yeah, I mean, A, doesn't come up on the history piece, but if this is an anticoagulated person, then they should be coming in. But again, if she had capacity, she could still say no. But if this person's like really, if it is more of a GCS3, like they're struggling to stay awake, if I feel that she doesn't have capacity, if I'm not getting that kind of clear, consistent understanding of what her risks are, Also, if I don't have a good, safe backup alternative, like if this person is out by themselves, I don't have a responsible person to leave them in the care of, then at that point I'm obligated to keep that person safe. And then I'm talking more the direction of, I'm sorry, but I can't leave you like this. So that the capacity piece is a big swing there. But then yeah, kind of the ultimate safety of that person is what plays in for me.
Right, and I think about it with this, that the patient has been drinking at some point. If they wanted to just immediately get in their car and drive home, there would be some consequences of that. So there would be things that we might want to look at here. Um, what do you think the most important things to document in this case are?
Yeah, so I think this is definitely one where, if I'm going to be just doing the check boxes in my run sheet, which again, check boxes, while frustrating, are how we can do things like pull data and then analyze calls after the fact. But, especially if I'm going to document potentially that we're signing this person off, if I have a not normal GCS, like I'm going to be pretty darn clear in my narrative about that whole capacity assessment piece of, this person was speaking in full sentences, this person was speaking coherently, they were consistent, they were understanding of risks, really trying to build that I did that capacity assessment and I felt that this person could make their own decision. And I'm also kind of clearly documenting what the alternative plan was or who's caring for this person or where they're going to go. And to one of my earlier points too, this is definitely one where, if this person's being left in the care of a friend, family member, etc., I'm getting a witness signature here for sure that's saying, yes, I was part of this discussion. Yes, I know you told my friend I want them to go to the hospital. I understand that they don't want to go. I'm going to be with them. So definitely getting that signature piece um, if they are going to be signing off here.
Great, I would concur. Thank you.
All right, I want to recognize our time, make sure we're leaving a couple minutes for folks to ask questions here too. Um, all of this to say, these are two cases. These are drops in the bucket of all of the difficult encounters that each and every one of you are coming across on a daily basis. Each of these is going to be context dependent. There's no single answer for any of these. And without being cliche about it, like this is hard work. This is the part of our job where it is the practice of medicine. You can have a textbook, you can have the most perfectly written protocol, and you can still never capture all of the environmental and social factors that will play into any given scenario. So for the first nod, it's just major kudos for going through this on a day-to-day basis because what we do is hard, and a lot of people also don't fully understand what we do, especially what the pre-hospital side does to get folks to the hospital is very underappreciated. And just want to acknowledge that we see that, but not everyone does. But from the medical decision making side, the big reminder and takeaway here is that it is a fluid process, and to not get that early closure, constantly be thinking about, is what I'm doing working, yes or no, and constantly get that extra data back and reframe and re-guide what you're going to do going forward. From that ethical piece, there are those 4 core pillars that define biomedical ethics that you can take entire courses on those 4 pillars. And I'm happy to go on rants about them too, because I think ethics is a really interesting topic in medicine. Remembering that your own experience plays into this, the more you do this, I will say the less hard it gets. I will never say it gets easier. I'll just say it gets less hard, but it still is a really hard thing with some of these dilemma type cases. Remembering that shared decision making is also your friend, and that shared decision is with the patient, it's with online medical consultation, it's with your team members on scene, it's with friends and family members of the patient. So that shared decision really can involve as many or as few people. Really, though, as if you can get more involved, the more complex it is, it can be really helpful. And then a quote that Eric threw in here, but Dr. Kate Zimmerman, this is something that when I was training as a resident too, was kind of one of her big takeaways. And we couldn't get the exact wording down, but we tried to do the best we could. But one of her big things to preach on is that it's not the responsibility of the patient to prove that they're sick, but rather it's our responsibility as clinicians and caregivers for this patient to ensure that they aren't. Which is to go as far as to say the patient isn't necessarily going to come to you and say, hi, I'm having my intracranial hemorrhage right now from my head injury. Please take care of me. But it's your job to make sure you're doing a thorough exam, use all the tools available to you, checking a sugar, checking a 12 lead, doing a head to toe exam, and making sure that you're not missing something. Don't get that early closure. Don't just say, oh, this is obviously anxiety when they're actually having their big STEMI. So we have to give a nod to Kate, because Kate very much is a big proponent and advocate of this kind of avoiding early closure, and reminding that it is on us as clinicians who are trained to make sure our patients aren't sick and to identify when they are by doing good, thorough assessments. So to that, I will say we are right at 2:00. So for folks that do need to dip off, by all means, head off to your other spaces. Appreciate you all for being here. We will stay on for a couple more minutes to see if other questions do pop up here in the chat or in the Q&A. But otherwise, Eric and I are around often. Reach out to us by email. Come find us here in Portland if you're ever down this way. I can't help but not shamelessly plug as a reminder that 2 weeks from now, the Maine Medical Center EMS conference will be happening here too. So we will all certainly be around for that. Come find us and chat with us there. If you haven't already and you're around, by all means, would encourage you to sign up. We have a really great lineup that Eric primarily has been doing a lot of work to get this set up. So very excited to have that. Hopefully see a lot of you folks there in 2 weeks. And otherwise, I hope you guys have a good rest of your day.
Thank you very much for attending.